Good morning.
Good morning, sir.
Who is going to present today?
Sir Manisha.
Okay, you can start.
Okay, sir. I am presenting a case of 30-year gentleman, Hindu by religion, a resident of Varanasi, admitted in the surgery ward on 22nd December 2020 with the alleged history of road traffic accident by cartwheel on 7 December 2020, after which the patient presented to us with chief complaints of pain in the left foot for 15 days, swelling in the left foot for 14 days, pus discharge from the swelling for 10 days, and ulcer over the left foot for 10 days.
So we shall go to the next slide.
Okay, sir. History of presenting illness. The patient was apparently asymptomatic when 15 days back when he met with an accident with cartwheel, after which he developed pain in the left foot, which was initially dull aching, progressive in nature, and gradually increased in intensity. Swelling in the left foot for 14 days, which was limited to foot and gradually increased in size. He was admitted to the hospital and dressing was done. After 4 days, the swelling burst open and pus came out. Then swelling decreased in size. The patient then developed black discoloration of skin, so debridement was done. Since then, he has an ulcer over the foot associated with pus discharge.
Yeah, why there should be pain which will increase after a few days? What can be the reasons for that?
Sir, after a few days, the pain can be increased, maybe because of the infection that occurred in that swelling, or also due to ischemia.
Go ahead. Yeah.
Past history, there's no history of any previous surgery. There's no history of any chronic illness in the past. Family history, the patient is married and has 4 children.
The past
There is no
history,
history.
which specific
Yes,
illness
sir.
you want to ask this patient?
Sir, we want to ask about diabetes and tuberculosis in chronic illness. And uh, sir, we should also ask about the history of any similar illness in the past and history of blood transfusion in this patient. And we also want to ask about history of
History of
burn.
birth. Now, why the blood transfusion?
Sir, because to see if the person has any severe anemic symptoms or if he had anemia in the past, because that can also be one of the reason for non-healing of the ulcer.
Go ahead.
Family history, the patient is married and has 4 children. There is no history of any chronic illness in the family. Personal history, the patient is mixed by diet. There's history of smoking bidi for 8 years, half a bundle daily, tobacco chewing for 10 years, and alcohol drinking for 7 years. Bowel and bladder habits are normal. History of taking some medication for pain, and there is no history of drug allergy.
What is the relevance of smoking here?
Sir, smoking, the relevance of smoking would be it is very peculiarly associated with Buerger's disease and other peripheral vascular diseases. Smoking by itself has nicotine and can lead to, which is a vasoconstrictor, so it can also interfere with the healing of the ulcer.
Next slide. Go back. Go back.
General,
Any history missing here? Or is it
sir, sleep-wake cycle we have not asked.
how the sleep cycle will be relevant in this patient?
Sir, if the patient was a diabetic or it may interfere, sir. So I'm not very sure.
I think that is not very important also.
Okay, sir.
For the sleep cycle is not very important. Go ahead.
General examination. The patient was examined in a well-lit room after taking proper consent. The patient is conscious, cooperative, well-oriented to time, place, and person with vitals, temperature, afebrile, pulse 84 per minute, blood pressure 110 by 80 mmHg, no pallor, clubbing, cyanosis, icterus, lymphadenopathy or edema. There is no koilonychia.
Why specifically about the koilonychia here?
Sir, again to see for anemia, to rule out anemia.
Go ahead.
Local examination. On inspection, there is a single large ulcer present on the dorsum of left foot, extending from 5 centimeter away from the great toe to lateral malleolus. It is irregularly shaped, nearly 15 into 7 centimeter in size. The margin is inflamed and edematous. The edge is sloping and punched out. Floor has some slough present. The base shows underlying muscles and bones. The skin around the ulcer is hyperpigmented.
This is your finding on inspection.
Yes, sir.
What is the margin here?
Sir,
What do
it
you
is
understand?
inflamed and edematous margin.
What do you understand by the margin?
Sir, margin is the line that demarcates the normal epithelium from the ulcer.
What is the edge?
Sir, edge is the area between the margin and the floor of the ulcer.
Said the edge is sloping and punched out.
Yes, sir.
Does that mean?
Sir, sloping, generally the edge sloping is seen in case of a venous ulcer or a healing ulcer. Uh, and a punched out ulcer is seen when all the layers of the tissue are being destroyed at the same pace, and it is usually seen in neurotrophic, introphic ulcers or arterial ulcers. And also it is characteristic of gummatous ulcers.
When you find a sloping edge of a ulcer, what else can you
Yes,
see in a healing ulcer? Sloping edge suggests the healing ulcer. What
yes, sir.
else can you see on the edge of the ulcer?
Sir, on the edge, we can also see the granulation tissue, the color of the granulation tissue. If it is healing, we will see three zones, red, white, and blue zones. Red, blue, and white zone. The red zone shows the granulation tissue growth, and white zone is the fibrotic zone, and the blue zone is the intermediate zone where there is some granulation tissue.
Find a blue lining there, okay? Specifically.
Yes, sir.
You
A blue
mention about the
lining.
blue lining here, and this blue lining is an indication of that there is
Healing.
healing edges there. So it is that there is a mucous membrane or the epithelium which is there is growing there in that area. So that is also important of
Yes,
the
sir.
blue line that suggesting of the healing ulcer. What are the other types of the edges which are there?
Sir, apart from sloping and punched out, the edge can be undermined edged, which is characteristically seen in tuberculosis. It is because the subcutaneous tissue is destroyed more than the
Ah,
skin, and thus the skin is overhanging. And sir, apart from that, the edge can be raised and beaded edge, which is seen in rodent ulcer, and it can be rolled up with everted margins, which is seen in squamous cell carcinoma.
Khushbu,
Yes, sir. Yes, sir.
tell what is the floor of the ulcer?
So, so the floor of the ulcer is which is surrounded by the walls, and basically which can have various substances like debris or other pus or other discharges.
Floor of the ulcer is basically the actual ulcer which is there, okay, which you inspect. You do not palpate the floor of the ulcer. You inspect. What do you understand by the ulcer, by the way? What is the meaning of ulcer?
So ulcer is any discontinuity in the epithelium.
Like if you make a surgical incision, is that a ulcer or not?
No, sir.
What is the
So,
ulcer?
so ulcer is a discontinuity in the epithelium, and especially when it's infected or when the epithelium is not normal as the surrounding.
Like if the epithelium of a cancer of the tongue is there, will that be ulcer or not?
So if it's this, so it can be called ulcer if it has a margin, a base.
Kirti? Kirti Sahu is there.
Yes, sir.
Tell what is ulcer.
So the ulcer is mainly the break in the continuity of epithelium or mucous membrane, skin or mucous membrane.
With so that will make
So
like
with
if you're making a surgical
molecular
incision,
death
that
of
is
the
also
surface epithelium. So surface epithelium का सर molecular death हो जाता है उसमें.
molecular death. That is very important. So there has to be a molecular death of the tissue. So then you label that as a ulcer. So there is a break in the continuity along with loss of tissue or molecular death of the tissue. Okay? That is defined as the ulcer. So when you see this floor which is there, floor is basically the whole ulcer which you inspect. What are the things you have to inspect on floor? Kirti, what are the things you have to inspect on floor?
So granulation tissues,
Yes,
color of the
granulation tissue. Yes. Color. Yes. What else?
so
Any
no, don't have.
discharge from there? You can see the discharge from the floor. That it is a small discharge is there, or it's a copious discharge is there. The type of the discharge, whether it is just a serous discharge is there, or it's a seropurulent discharge is there, or it's a purulent discharge is there. This is all these things are seen on the floor. Now, what are the various types of granulation tissue?
Yes, sir.
Tell on your video and tell what are the various types of the granulation tissue.
So it could be red granulation tissue in
On,
case of
on your video first. On your video and then answer.
so it could be red granulation tissue in case of healing ulcer, or it could be in case of spreading ulcer. I don't know.
Spreading ulcer, what type of the granulation tissue will be there?
The inflamed edematous.
Type of the granulation tissue, what color it will be. Usually if it is a pale color is there, then what does that suggest? It is a callus ulcer or a chronic ulcer. It is relatively a non-healing ulcer. It is not a spreading ulcer, but it is a callus type of ulcer or a non-healing and a chronic ulcer. Spreading ulcer, what will be there in the floor? It will be dirty. Yeah? There may be slough may be there. In the case of a spreading type of ulcer. Yashwant Reddy. Yashwant Reddy. Tell what do you
Yes, sir.
understand what do you understand with the base of the?
Sir, below the floor of the ulcer, which is formed by the bone. Sir, this is the base of the ulcer,
On which the ulcer
which
is
is
sitting.
formed by the underlying structure, sir, on which ulcer is sitting. On which the floor of the ulcer is sitting is base of the ulcer.
So can you tell the base of the ulcer on inspection? Okay, Manisha is describing the
No,
inspected finding. So is that correct
no,
or not
sir.
on the inspection?
No, sir. Base of the ulcer cannot be seen on inspection.
It has to be palpated.
No.
So base is always palpated. Okay. So this is not correct on inspection.
Okay, sir.
So like here in this case, what can be the structures which can form the base of the ulcer? In this particular, you can see the photograph here.
Yes, there is.
So what do you think which can form the base of the ulcer here?
Sir, metatarsal bones.
Yes. So it may bone may be there. Yes.
Sir, second, third, and the fourth metatarsal bones can be seen.
Maybe second, third, and fourth metatarsal may be there. And proximally,
Sir, bones that are involved in the ankle joint. Some of the tarsal bones.
tell the few names of the tarsal bones.
Sir, calcaneum, talus,
Uniforms.
cuneiform bones.
So do you think this will be only the bone which will be there or something else can also be forming the base?
Sir, underlying tendons passing through that area.
Underlying tendons may be there, muscles may be there, or
Any vascular
bone.
structures passing through that area.
Right. Now in this patient, the skin around the ulcer is hyperpigmented. Manisha, what is the meaning of that?
Sir, skin is usually seen hyperpigmented in venous ulcer. Here in this case, it is hyperpigmented maybe because of the infection. There is hemosiderin deposition, and which makes the skin hyperpigmented.
Where is the usual site of the venous ulcer?
Sir, usual site is in the lower one third of the leg. Usually, it is above the medial malleolus, as the great saphenous vein is most commonly involved.
What is that area called as?
Gator area.
Gator say. So why does the venous ulcer are most common in this gator area?
Sir, because we have a number of perforators and communicating channels between the deep vein and the superficial vein in this area.
There is
And
overcrowding there.
yes, sir, overcrowding.
Overcrowding of the perforators are there. Anything else?
Sir, it is also one of the weight bearing areas. And sir, also because of the incompetency of the walls.
Yes. Because of incompetence of the walls, what happens there? There is
Sir, there is
Venous hyper.
backflow of blood, venous also, venous hypertension.
venous hypertension.
Yes,
And
sir.
this venous hypertension is maximum, the impact goes over the long saphenous vein.
Ankle, long
Yes,
saphenous
and
vein.
long saphenous vein is situated over the ankle. So there is a maximum venous hypertension. And third, if you
Yes, sir.
see in that area, relatively, there is hardly any muscle tissue there, that area.
Yes, sir.
It is directly sitting over the bone there, over the tibia there. Okay, so these are the reasons that why you get the venous ulcers in the gaiter area, because of the maximum venous hypertension in that area, because of the crowding of the perforators in that area, and because of the almost the subcutaneous tissue in that area, you get the venous ulcer in the medial side near the medial malleolus.
Yes, sir.
And what is the cause of hyperpigmentation? Why?
Uh, Sir, due to stasis of blood and destruction of RBCs, there is formation of hemosiderin which gets deposited, leading to hyperpigmentation.
So hemosiderin is one and melanin is the other. Okay, there can be deposition of the melanin in that area. One is the hemosiderin and another
Yes.
is the melanin which is there. That causes the pigmentation around a venous ulcer. Go to the next slide.
On palpation, the temperature was not raised. The tenderness is present. There is a single large ulcer present on dorsum of left foot, extending from 5 centimeter away from great toe to lateral malleolus. It is irregularly shaped, nearly 15 into 7 centimeter in size. The margins are inflamed and edematous. The edge is sloping and punched out. The floor has slough present and some bleeding points on touch. The base has shows underlying muscles and bones, and skin around the ulcer is hyperpigmented.
All repetition is there, isn't it? Because
Yes, sir. And sir, also I'd like to add that we have not examined, we have not written anything about the other limb or the rest of the limb in this case also, and the other limb also.
ideally you have to always examine the normal limb first. Okay. So whenever you
Yes,
are
sir.
starting
Yes,
your
sir.
presentation, the local examination, so
Yes,
you
sir.
will say that the right lower limb obviously is normal. Okay. And then you will go to the left lower limb. Right.
Yes, sir.
So on palpation, what are the different things you palpate, which is not there on the inspection way?
Sir, when we begin, we first check the temperature of that limb and also the other limb by the back of the hand. Then we will also see for tenderness. Sir, apart from that, we can palpate the edge, margin, floor, and definitely the base. We will also try to feel any induration in the base. If it is there, it is most commonly seen in malignancy or hard. It will be very hard, and induration can also be seen in syphilitic or gummatous ulcer. Sir, apart from that, we should also try to feel any we should also palpate the depth of the ulcer, and sir, we should also palpate if there is any nerve if there is any nerve involvement or nerve thickening in the rest of the limb, we can try to palpate that.
Now, how do you know that this ulcer is sitting on the bone? How will you
Sir,
know that this ulcer is sitting on the bone?
sir, when we will try to palpate the base, it will be very hard, and it will not be mobile.
Now, in this area, because there is not much of the underlying structures which are there.
Yes, sir.
Otherwise, if there is ulcer like in the thigh it is there or in the calf it is there, try to move the ulcer.
Yes,
If
sir.
you are able to move, then it is not fixed the underlying bone which is there.
Bone.
So if you are not able to move, then probably the base is formed by the bones. But in this area, it is very difficult because there is hardly any subcutaneous structure which is there. So it will be very difficult to say that whether it is sitting over the bones or it is over the muscles or the tendons. Okay. Go to the next slide.
Yes, sir. There are no palpable inguinal lymph nodes. All the arterial pulsations are normal. There is no motor or sensory loss, and the joint movements are normal.
Now, you should only palpate the inguinal nodes, or should we palpate the other nodes also?
Sir, we can also palpate the axillary as well as the cervical lymph nodes. But sir, since this one and popliteal lymph nodes also we can palpate in this case since it is in the lower limb. The ulcer is there in the lower limb.
We are talking about the local examination here. Local
Sir, in
examination
this
will
one
not
we will
the
only palpate
cervical and the
inguinal and
axillary.
popliteal. Yes, sir.
And palpate the popliteal lymph nodes, and you can palpate the inguinal.
And inguinal lymph nodes.
Then in the pulsations, which pulsation you want to feel?
Sir, we will feel all the pulsations of the distal and the proximal arteries, distal and proximal to this ulcer. We will feel the dorsalis pedis artery, then the anterior tibial, the posterior tibial artery, and then we will feel for the popliteal artery and the femoral artery.
Manisha?
Yes, sir.
Manisha. Okay.
Yes, sir.
Manya.
Am I audible?
Manya?
Yes,
Manya?
sir. Yes, sir.
Well, how do you feel the dorsalis pedis artery?
Sir, dorsalis pedis artery is felt between second and third metatarsal.
Second and third metatarsal.
Sir, it is
First,
felt just.
is it the first and second or second and third?
Sir, I don't remember.
Manisha, tell.
Sir, it is felt just lateral to the extensor hallucis longus tendon between the first and second.
In the first and second metatarsal, just
Yes, sir.
lateral to the external hallucis.
Extensor
On the
longus.
proximal side or the distal side?
Sir, on the proximal side because the artery end at it reaches towards the toe.
Should be always palpated on the proximal side.
Yes, sir.
And you cannot feel it distally because the artery dips toward the,
Dips, yes, sir.
yeah. So you have to always feel it proximal. Now, against which bones you feel the dorsalis pedis? You know, all the arteries which are felt against the bone. So, against which bone you feel the dorsalis pedis artery?
Mm. Sir, I don't know.
So navicular bone.
Navicular bone and sometimes the medial cuneiform. Where do you feel the anterior tibial artery?
Sir, it is felt anteriorly between the both the malleoli. Sir, at the matlab, lower end of tibia.
Right. And this will be felt against which bone?
Sir, tibia.
Tibia, lower end of the tibia.
Yes, sir. Lower end of the tibia.
Where do you feel the posterior tibial artery?
Sir, posterior tibial artery is felt, sir, midway between the medial malleolus and the tendoachilles.
And against which bone it will be felt?
Uh, mm, Sir, I can't recall.
Felt against the calcaneus.
Okay, sir.
Felt against the calcaneus. Isha,
Yes, sir.
where do you feel the popliteal artery?
Sir, popliteal artery is felt behind the knee joint, sir, in the popliteal fossa. Um, so,
What are the various positions you can palpate the popliteal artery?
sir, I don't know.
Popliteal artery can be felt
Sir.
in
Sir,
supine
we will
position. Tell Manisha.
Sir, we will ask the patient in supine position. We'll ask him to lie down in supine position, and we will flex the knee at about 40 to 45 degrees angle, and the heel will be rested on the bed. And then we will try to feel the popliteal artery with the fingers of both the hands in the popliteal fossa. And sir, we will feel it between the two femoral condyles.
Okay. That is one position. In any other position,
Yes, sir. We can ask the patient to lie down in the prone position, and then we can try to we will fold the knee passively, and then we will try to feel it in the popliteal fossa.
any other way to appreciate the popliteal position?
Sir, there is one test. Mm, Sir, in which the we will ask the cross-legged test or Fuchs test, through which we can feel the popliteal pulsation. We will ask the patient to sit cross-legged with one leg above the other, and we will try to talk to the patient and divert his mind, and we will try to see the oscillatory movement of the foot of the other leg which is lying over.
You will not palpate here, but you will just
Yes, sir.
inspect.
We will not palpate here. Inspect.
Okay, you just do the inspection to see for the movement of the leg in front, which is there.
Yes, sir.
Now, where do you feel the femoral artery?
Sir, femoral artery, we feel in sir, just in the groin region, just below the inguinal ligament, sir, somewhere in between the pubic symphysis and the anterior superior iliac spine.
What is that point called as? What is the difference
Mid-inguinal
between a
point.
mid-inguinal point and midpoint of the
Mid-inguinal.
inguinal ligament?
Sir, midpoint of the inguinal ligament lies in between the pubic tubercle and anterior superior iliac spine, whereas midpoint of mid-inguinal point lies between the pubis symphysis and the anterior superior iliac spine.
You feel it in the mid-inguinal. Okay.
Yes, sir,
Against which
at the
bone?
mid-inguinal point.
Against which bone?
Sir, against the pubic bone.
head of femur.
Head of femur. Okay. It will be felt in against the head of the femur. Next is there is no motor or sensory loss. So,
Yes,
what
sir.
did you test for that?
Sir, for sensory loss, we will see for fine touch, crude touch, pain, temperature, and proprioception. And in motor, we will we will ask the patient to move the limb against resistance, or we will check for the grading from 0 to 5. And also we can see for atrophy of the limb, if it is there, we can measure it.
Now, in the sensory loss, like if this patient is a diabetic patient, which is the earliest sensation which is lost?
Sir, hot and cold, I mean temperature.
Something goes before that.
Temp Sir, the, sir, there is tingling and numbness.
First sensation which goes is the vibratory sense.
Okay, sir.
So you have got a tuning fork with you, you can check for the sense of vibration. Okay, but
Okay, sir.
because in a surgical patient you will hardly have a tuning fork with you. So the next you can appreciate the joint sense. So you try to move the joint and ask the patient about the joint. So that is the next sensation which is wrong. The pain
Yes, sir.
sensation, the touch sensation, the temperature sensation, they are lost later period. So first is the vibration sense which is there in the diabetic patient. I'm talking about the diabetic patient. So if the diabetic foot is there, then in that case, that is the first sensation. And then is the joint sensation. Now, why did you want to assess the joint movements here?
Sir, to see if there is any to rule out osteomyelitis.
Was it there's a
Healing is poor.
either the osteomyelitis is there or like the patient has got the frozen joint because the inflammation.
If a frozen joint, yes, sir. Yes, sir.
So that may be there. That is the you have to check for the joint movements. Next slide. Any other slide after that? Yeah, tell about that.
Sir, on systemic examination, the higher mental functions were normal. There is no sensory motor deficit, and deep tendon reflexes are normal. On cardiovascular examination, S1, S2 was heard, and there is no murmur. On respiratory examination, bilateral air entry is equal. There is no added sound, and trachea is present in the midline. On abdominal examination, it is soft, non-tender, and with no organomegaly.
Now, in this patient of a ulcer which is there on the foot, can you get any abnormality in the abdominal examination?
Sir, sir, a lump, if in case of a venous ulcer, we may get a lump in the abdomen.
Which lump you are interested?
Sir, I'm not able to hear the question.
I'm asking which lump you are interested.
Uh,
Which lump can cause the venous ulcer?
So
sir,
pelvic mass.
any,
Any pelvic mass.
sir,
Okay.
any lump, yes, sir, any pelvic mass that will obstruct over the IVC, inferior vena cava.
Or obstructing the IVC or pressing over the iliac veins.
Yes, sir.
Any pelvic lump which is there. Now, which is the commonest cause of varicose veins in the females, which may be temporary?
Pregnancy.
Pregnancy. So a pregnant uterus can compress over that, and also because of the hormones which is there can be the varicose veins in a female. And once the pregnancy is over, then these veins may disappear or may also persist. Now, if you have to palpate the abdominal aorta or the pulsation, where you will feel it?
Sir, in
Manya.
the,
Manya is there.
Yes, sir. Sir, it is felt just above the umbilicus on the left side.
Why not below the umbilicus? Why not below the umbilicus?
I don't know.
Because it divides into now the two common iliacs, and that is the location of the bifurcation of the aorta. Now, umbilicus is situated at what level of the vertebra?
Sir,
T12.
L1.
Hmm?
L1.
What is it? Not L1.
Sir,
Sir,
T10.
L3,
L2
L4.
level.
It is at the junction of the L3 and 4. Okay, junction of L3 and L4 is the location for the umbilicus, and the aorta divides into two common iliacs at that level, and that is why you have to always feel it above the umbilicus, and as it is situated on the left side, so you have to feel it on the left side. Okay. Next slide. That's the last one. So, Manisha, what is your
Yes, sir.
diagnosis in this patient?
Sir, sir, in my diagnosis, this may be a traumatic ulcer superseded with infection and ischemia. And sudden differential, I'd also like to keep arterial ulcer or ischemic ulcer.
So, do you think it's an acute ulcer or it's a chronic ulcer?
Sir, the history of patient is for less than 2 weeks, so I would say acute ulcer.
What do you understand by acute ulcer and what do you understand by chronic ulcer?
Sir, if the ulcer has been present for less than 2 weeks duration, it will be acute. And uh, sir, there is also like in this patient, there's also edema present and other signs of acute inflammation, pain, edema, the swelling, the margins are ragged, and edematous. Uh, Whereas in a chronic ulcer, it will be the history will be of more than 2 weeks, and mostly it will be a non-healing ulcer with pale granulation tissue.
The first is the duration of the ulcer. The
Yes, sir.
duration of the ulcer, if a ulcer is not healing in spite of the adequate treatment and it is lasting for more than 6 weeks to 3 months. Okay. So the break line is the 6 weeks to 3 months, not 2 weeks. It is 6 weeks is there.
Okay.
So if a ulcer is persisting even after 6 weeks, or some people even have that it is 3 months also. So between 6 weeks to 3 months, if it is there, then you label it as a case of a chronic ulcer. Otherwise, it is an acute ulcer. Okay, so that is the duration which is important for that. So your first diagnosis is a post-traumatic ulcer. But why such a big ulcer which is there? What is the reason for that?
Sir, it may have been spreading due to infection and ischemia.
Yes. In this patient, probably. So can you think of that? What is the sequence of events which has occurred in this patient? So there was a trauma was there, and what happened
Yes,
after
sir.
the trauma?
Sir, after the trauma, the patient had a swelling in that area, and due to increased filling of the pus inside, and due to increase in the
What you will
temperature,
call that?
and also
Trauma followed by
uh, suppuration,
cellulitis.
cellulitis. Yes, sir.
So there is cellulitis is there, and there was an abscess formation
Yes, sir.
which busted out, and then it formed
And sir, from the
ulcer there,
ulcer.
and the debridement was done.
Yes, sir.
This patient underwent the debridement, and that is why now there is a ulcer is there.
Yes, sir.
Mohammed Wasim,
Yes, sir.
so how will you investigate this patient?
Sir, culture sensitivity.
Of what? Culture sensitivity of what?
Sir, age of the ulcer. Sir, of the ulcer.
Now tell in this patient what are the various ways do the culture and sensitivity. What are the various ways you can carry out the culture and sensitivity?
Sorry, sir.
Mohit,
Yes,
Mohit,
sir.
tell if
Yes,
the
sir.
ulcer is there, what are the different ways you can carry out the culture and sensitivity for that?
So for culture and sensitivity, first we can take a swab from the edges of the ulcer. The second way is to take a wedge biopsy to find the culture and sensitivity.
You can
So
take
these
the
are the two
culture
ways.
from the discharge which is there. You know? The discharge which is coming out, you can take the culture of that. You can take the swab culture of that, or you can take the biopsy of, like the wedge biopsy set. You can take the wedge biopsy of that. Now, out of all these, which is the most sensitive one?
So wedge
Which is
biopsy.
so always a what is called a deep tissue biopsy should be taken. Should not take the culture from the surface, because surface will have the non-specific bacteria. So it is better always to take a deeper culture rather than the superficial culture. Now in this patient, what do you suspect? Which type of the organism will grow?
So it could be Staph aureus.
Any other bacteria? Manisha, you can off the presentation now.
Okay, sir.
Unshare your presentation. Any other gram-positive bacteria which can grow?
So I don't know.
Maybe streptococcus also. Yes, staphylococcus is there. There can be streptococcus also. Beta hemolyticus type of the streptococcal infection may be there. Or there may be polymicrobial. Both gram-positive and the gram-negative bacteria may be there. Maybe a polymicrobial infection may be there. You know what is the sensitivity of a staphylococcus bacteria usually? To which drug they are susceptible?
So vancomycin. If methicillin, vancomycin.
What type of the bacteria they are called as?
So, gram positives.
They are gram-positive, but anything specific for the staphylococcus? Which type of the bacteria are they?
I'm not getting the question.
You know the various types of the staphylococcus.
Methicillin
Staphylococcus
resistant.
Sir, methicillin resistant.
MRSA. No? That is one of the types. That is methicillin resistant
And VRSA.
staphylococcus aureus.
Coagulase positive methicillin resistant Staph aureus.
Right. So, if it is MRSA, what are the drugs which can be given for the MRSA?
So we can use vancomycin, and if they are resistant to vancomycin, we can use linezolid, streptogramins, teicoplanin.
So, the vancomycin or the linezolid which is there. These are the two most important drugs which are used for the MRSA.
Yes.
Now, if it is a streptococcus is there, which antibiotic can be given for the streptococcus?
So we can use amoxiclav, which includes amoxicillin and clavulanic acid.
Anything very old antibiotics still can be used for only for the
Penicillin.
streptococcus.
Penicillin.
Penicillin can. So you cannot use the penicillin for the streptococcus because they are resistant to that.
Yes,
But
sir.
streptococcus is one of the bacteria where still we can use the penicillin.
Penicillin.
Right. So you have done the pus culture and sensitivity for this patient. Then any other investigation?
Sir, we will do CBC, complete blood count, and
CBC for this patient.
LFT and yes, sir. Yes, sir.
By the blood one, what are the things you want to exclude?
Sir,
By
we
doing the
want to
CBC.
see,
Yes.
sir, we want to see for the raised TLC for infection, and hemoglobin for anemia, and sir, we can also do an ESR estimation for acute inflammation, and
Any other blood investigation very important?
CRP.
sir, CRP.
So that is
Blood
for the
sugar.
inflammation.
And
Okay.
So blood
sir, and
sugar,
blood glucose,
diabetes.
blood glucose.
Blood sugar. Now, blood sugar is very important because you have to
Yes, sir.
rule out the diabetes in this patient.
Diabetes in
So
this
you have
patient.
to check for the blood sugar. What other inflammatory markers can be done?
Sir, we can do CRP and sir, ESR, and we can do sir D dimer to rule out DVT, and
Remember the COVID one?
sir
All those
serum ferritin.
ferritin. Yes. What else? What are the other tests which are done in the COVID?
Pro. Sir, also interleukin 6.
Interleukin 6.
Sir, procalcitonin.
Procalcitonin. So these are just the same markers which are there for the COVID. So you can do the D dimer,
Yes, sir.
you can do the interleukin 6, you can do the ferritin, the procalcitonin. All these can be done. Any other investigation? Sir. Muskan.
Sir, we will do an X-ray of the.
Muskan.
Yes, sir.
What are you? If X-ray of the foot is done, what are the things you can see in this patient?
So we can, in the X-ray, we can see for the bone involvement if there is any osteomyelitic lesion in the bone, and so if there is any deformity due to ulcer in the bony structure.
Okay. Now this patient had a trauma.
Yes, so access. So we can also see for the traumatic, so any fracture due to trauma in the.
That was the first thing to be seen here.
Yes,
So this patient had a trauma. You have to see if there is any fracture of the bone is there or not. Then you can see for if there is any osteomyelitis is there. If it would have been elderly patient, what else can you see? Like if it would have been 50, 60 years age patient, what can you see?
So any
On plain
joint pathology, gout, or any.
Yes. For any joint pathology.
So I don't know anything.
Manisha, what other things can be seen on the
Yes, sir.
plain X-ray of the foot in a patient who has got a ulcer of the foot? What other things can be seen on plain X-ray?
Uh, uh, sir, apart from what Muskan has told, sir, we have to tell in this patient only, like what other thing we will see.
If you would have been a diabetic patient, can you see anything on the X-ray of the foot?
Yes, sir. We will see osteo, sir, osteoclastic and osteoblastic changes.
So small traumas can be there, which can go unnoticed in diabetic patients.
In a diabetic patient, you can get the patient is having the osteomyelitis, or the patient may. What is Charcot's foot?
Sir, in Charcot, there is destruction of the nerve and the joint in an area which is well perfused due to nerve lesion or due to neuropathy.
So you can get the osteoporotic changes. Okay. So you
Yes,
may
sir.
find there is osteoporotic changes in a Charcot's foot. So if it is a diabetic patient, you can see the osteomyelitis or you can see the osteoporosis. Then a patient, elderly patient is there, you can see the calcified blood vessels there. Okay, you can see there's a calcified anterior tibial artery or the dorsalis pedis artery because of atherosclerosis. So that you can see on the simple plain X-ray.
Yes, sir.
Hashiri,
Yes, sir. Yes, sir.
okay, tell on your video and tell what other investigations you will do.
So color Doppler for venous ulcer.
Color Doppler. What do you understand by color Doppler?
So, so color Doppler, sir, in color Doppler, some uptake.
We understand by color Doppler. Tell what is Doppler.
So,
What do you understand by Doppler?
so,
Nidhi Kumari.
Yes, sir.
Tell what do you understand by Doppler?
Sir, Doppler is there is a Doppler law that states that according to the relative motion, means when two objects are moving on the same side or the opposite side, the frequency of the sound changes. There was a Doppler's law.
That is the Doppler effect. You know? But you know who is Doppler? Doppler is a physicist. Okay. He is from Austria. And he has described this Doppler effect which is there. And this Doppler effect means if some thing is thrown over something, it reflects back from there. And you can estimate that how much is the distance and the frequency of that. Do you know how the bat, they travel in the night?
So by bouncing their
Sir, by
sounds from
ultrasonic
trees.
wave.
By
So they
ultrasonic
throw
waves.
the ultrasonic waves. Bats, they throw the ultrasonic waves, and by that they can know that what is the obstacle which is in front of them. You know, how do you calculate that what is the speed of the ball in the cricket ground? How it is estimated? It is 140 or 120 or 100. How it is estimated? Right? How it is estimated?
So like when the ball passes in front of the scanner, the angle between the ball and the camera is taken, and using the Doppler effect, the distances,
Same
the
effect.
time
Yes.
difference. Yes, sir.
It uses the same effect, the Doppler
Yes, sir.
principle which is there, and that is the basic principle. You know, there are so many instruments which are involved in it, but that is the basic principle, that it uses the Doppler law for that, and you can estimate the speed of the ball. What happens in the, how does it help in the human body?
So to find
Like
the
if you
flow
are doing a
velocities
drill.
in the vessels.
So what is the flow here? What you are estimating?
So we are estimating the flow in the veins that may have been obstructed.
You are in the blood vessels. By this Doppler effect, you are estimating. So what is the thing which is there in the blood vessel? which
So
gives you
the
the Doppler effect.
the RBCs and the
RBC.
blood cells.
Flowing RBCs. The flowing RBCs which is there, that gives you the effect of that. Now, what is there in the RBC which gives you
Hemoglobin.
Iron.
the hemoglobin, and in the hemoglobin is the iron.
Iron.
Okay, so these waves are reflected by the flowing RBCs which contains the iron, and you estimate that how much the flow is. So what you will do in this patient, you will say that you will do a duplex scan. Rather than saying it's the Doppler one, you will always say it's a duplex scan you are going to carry out this. Now, Manisha, what do you understand by duplex?
Sir, in duplex scan, we do two things, ultrasound B scan as well as color Doppler.
So mix the two things. That is why it is called as duplex. So usually it is the B mode
Yes, sir. We
ultrasound
will
which is
see
there
both truncal and non-truncal
along with the
veins.
Doppler. So what
Yes, sir.
are the
That is on B
things
scan.
you estimate by the B mode ultrasound, and what are the things you estimate by the Doppler or the color? You know, this is called a color Doppler because it is coded color. So what are the things you are going
Color
to
building.
do in the ultrasound?
By doing a duplex.
Hmm?
Um,
What does the ultrasound tells you, and what does the
sir,
duplex, the Doppler tells you?
So anatomy of the valve or in the ultrasound, or in duplex there the reflux of the blood flow.
So
Patient defect.
ultrasound gives you the anatomy, while
sir,
Doppler will give the physiology.
yes, sir.
Okay, so that is the basic difference. Ultrasound will tell you the anatomy. So you want to see whether there is a femoral artery is there or the femoral vein is there, whether they are looking normal or not, what is the diameter of that artery which is there, what is there, the walls which are there in that, if there is any something like a thrombus in the artery is there or thrombus in the vein is there. So those all things can be seen by the ultrasound. While the Doppler will tell you the flow of that, whether the flow is normal or not, or whether the flow is reversed, flow is there. So it is going to tell you about the physiology of that. So in this patient, what is your interest? What you want to see in the duplex scan here? Nisha, what do you want to see in the duplex
Uh,
scan?
sir, in this patient, we want to see, sir, if there is any stenosis due to which there is uh, lesser blood supply to the area of the ulcer, and uh, sir, also, sir, deep venous thrombosis.
Yes, you want to see all those things in this patient, but probably all the things will be normal in this patient because you can feel the dorsal pedis artery.
Yes, sir.
You can feel all the distal pulsations which are there.
Yes, sir.
So probably all will be normal.
Palpation.
Prachi, what is ABPI? Prachi there?
Yes, sir.
What is ABPI?
Hello. Sir, it is ankle brachial pressure index.
Ankle brachial pressure index. So is that important in a patient who has got the ulcer of the foot?
Yeah, sir, I don't know.
Yes, sir, it is.
Nisha, is there any importance of doing the ABPI in a patient
Yes,
with the
sir.
ulcer of the foot? What is the
Yes, sir, it
importance?
is important. Sir, in AB, sir, the sir, in By measuring the ABPI, there will be two things. First of all, we will know if there is any arterial pathology. If the patient has not told us about any claudication or rest pain before, so the normal value should be in between zero point 0.9 to 1.3. But if it is lesser, then we will know about any arterial pathology. And sir, also in for the treatment in management, if we have to do a dressing, sir, in that if the ABPI is lesser than uh, point 9, 0.5, then we will, while dressing, we will keep the pressure to lesser than 30 millimeters of mercury. Otherwise, normally we keep it up to 35 to 40 millimeters of mercury.
Pratham? Pratham is there?
Yes, sir. Yes, sir.
Pratham, how you do the ABPI?
Sir, we measure the blood pressure of ankle and the blood pressure of legs, means of femoral artery.
Or the
And
femoral artery?
So we measure the systolic blood pressure of the ankle anterior tibial artery, divided by systolic blood pressure of the femoral artery, brachial artery. Sorry, brachial artery.
So you measure the pressure on the brachial artery and you measure the pressure over the dorsalis pedis or the anterior tibial artery or the posterior tibial artery. Okay. So it is ankle brachial. So at the ankle you are measuring the pressure, not in the femoral artery. So you have to measure the arteries at the ankle which are there. You measure the pressure. Do you require any instrument for that, or you can do it with the just the your BP instrument?
So Doppler USG, I mean, we will do.
Doppler USG is that you have to take the patient to the radiology department then for carrying out that. Which instrument is required to measure the ABPI?
So then sphygmomanometer.
Manometer is just for measuring the blood pressure. Here you require the handheld Doppler. Handheld Doppler. Have you ever seen that handheld Doppler or not?
no, sir.
I think
No,
sometimes you
sir.
go to the operation theater there, okay, and ask the sister to show you. She has that handheld Doppler with. Okay, so you go to the male surgical ward, third floor, and ask the sister there to show that what does the handheld Doppler is. The handheld Doppler is a small instrument which is there, which is of the pocket size, and it's a very small instrument like this instrument which is there, and by that you can measure the systolic pressure. So you apply the tourniquet as you apply in the sphygmomanometer, and then with the help of this, there is a probe which is there. You put the probe over the artery and measure the systolic pressure. So Pratham, what is the normal ABPI?
Okay, sir.
Sir, 0.9 to 1.2.
1.1. 0.9 to 1.1. And what is the abnormal ABPI? If it is
Sir, either less than 0.5.
both ways, and either it is less than 0.9 or it is more than 1.1. Both are abnormal.
Or more.
So if it is less than 0.9 is there, then what does that suggest?
It means that the legs are not getting enough supply. So means any blockade in the
Any
peripheral
feature of
artery of the leg.
ischemia is there. Okay, yeah. So any feature of ischemia is there because the less blood supply in the limbs, so the pressure will be less than 0.9. And if it is more than 1.1, what is the problem there?
Diabetes mellitus.
Yes, patient of like a diabetes is there. So there is what happens in the diabetes?
Calcification, if it is there. Or,
What happens in diabetes?
sir, in which there is calcification of the arteries. Calcification.
Calcification. So not only in the diabetic patient, but as such the patient is having the like atherosclerosis
Sir,
is there.
end stage renal disease also. Yes, sir. And ESRD also.
So there is increased calcification is there, and because of that, abnormal means the pressure will be approximately like 1.3 will be there. Okay. Priyanshu,
Yes, sir.
any other investigation you would like to do? Any other investigations you would like to do? Like if you want to know that really the bones are involved or not, what investigation can be done? You really want to know whether the bones are involved or not.
Sir, X-ray.
X-ray we have done. X-ray we already
Serum
done.
alkaline phosphatase.
No, involved in the bone. You want to see, like in this patient, I want to see whether the underlying bones are normal or not. What investigation you will do?
CT scan, sir.
You can do the CT scan, but the MRI is better. Okay. So you do the MRI of the foot, and you can appreciate that whether there is an involvement of the bone is there or not. Okay. So these are all the investigations which will be done. So in a case of a ulcer, the investigations carried out are you have to carry out the CBC, you have to carry out the blood sugar examination, you have to carry out the renal function test of the patient, then you have to carry out the culture and sensitivity, X-ray of the foot, and duplex examination. So these are the investigations which are usually done for a patient with a ulcer like this. Okay. Oscar?
Yes, sir.
Oscar?
Yes, sir.
So how you are going to on your video?
Sir, I am turning
your
on,
video.
Sir. I am turning on, sir, but there seems to be an issue, sir.
So tell how you are going to treat a patient like this. Puneet Gupta?
Yes, sir. Sir,
So how you are going to?
we will first clean the wound, then apply local antibiotics over it.
Tell what are the basic aim of a treatment of ulcer?
So we try to stop any possible infection, sir. Firstly, we clean the wound, dressing.
Your final aim is that this ulcer should heal.
Yes,
okay.
Sir.
So your final aim is healing of the ulcer. Now there can be several problems which are there in making the ulcer heal. So what are the various problems which are there which will not allow you to heal the ulcer?
Possible infections.
You can basically divide into
Sir, there can
the
be local
systemic
causes and
factors
systemic
and the
causes.
local factors. No?
And-
There can be systemic
Yes, sir.
factors may be there, and there can be local factors may be there. Now, in the systemic factors, what are the systemic factors which are important?
Sir, diabetes, most important, anemia, and sir, avitaminosis, uh, sir, steroid, if the patient has been taking steroids for longer duration.
Any immunocompromised. You know? The patient
Yes,
is
sir, immunocompromised.
immunocompromised because of any reasons. The patient is taking the steroid. The patient is patient of a malignancy and taking the drugs for that, the chemotherapy for that. The patient is HIV patient is there. So any immunocompromised situation which is there, you have to improve that. And what are the various local factors which are there, which are important? And definitely the nutrition of the patient. Okay. So nutrition of the patient is very important.
Yes, sir, nutrition.
So what are the various local factors which are there?
Sir, in local factors, if the ulcer is over a joint or if there is excess mobility of the ulcer area, then it will take time to heal. And if there is any persistent, if there is repeated trauma, recurrent trauma, like in case of ulcers in the mouth, there is repeated trauma due to the teeth. And sir, also if there is any foreign body present in that, then it will take time to heal. And if it is also if there is some infection over there.
Now, the most important thing which is there is the infection. So you have to definitely control the infection. And what are the various ways you can control the infection?
Sir,
Antibiotic.
sir, we will clean the wound thoroughly. We will do a wet dressing, and we will also we will also give antibiotics to the patient based on culture sensitivity.
Okay.
And sir, if it is required, then we can do regular cleaning and dressing of the wound.
So in all what it is called as, you have to this is called a wound bed preparation. Okay. All these things is called as wound bed preparations. And one of the very important component of the wound bed preparation is the debridement. Radhika, do you know what is debridement? Is Radhika there? Radhika, are you there?
She has not
Again,
joined the class.
is not joined. Okay. Kapil Sharma again, come back to the roll number 23. Kapil Sharma. Are you there, Kapil?
Yes, sir.
Right. Tell what do you understand by debridement? Have you heard the debridement or not?
No, sir.
Never heard about the debridement? Okay. Kushbu? Kushbu?
Yes, sir. So, debridement is basically cutting unhealthy tissue from the skin so as the area heals quickly.
Basically, debridement means
The dead
cleaning.
tissues.
Okay. So you have to clean the dead tissues which are there. So, you know what are the various ways of the debridement? How can you do that? because debridement is the most important component of the
So by incising the
wound
unhealthy
bed
area and
preparation.
removing it.
Tell that.
Um,
Manisha, do you
sir,
know how
I
can you
could not
debride
hear
the
you.
wound? What are the various ways of debridement, or what are the different types of debridement? Manisha, do you know what are the various types of debridement?
Sir, uh, sir, a few maybe. Sir, autolytic debridement, biological and enzymatic debridement, then surgical debridement with the sharp instruments, mechanical debridement.
So there are normally 5 types of the debridement. So just to remember that, you can
Yes, sir.
remember beams. 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 B is biological. E is enzymatic. A is autolytic. M is mechanical. And S is surgical. You can remember the beams. BEAMS. Now, out of all this 5 debridement, the most important and most effective debridement is the surgical debridement. So
Surgical
you,
debridement.
with the help of the scalpel and the scissors which is there, you carry out the cleaning of the wound, the dirty things which are there. So there will be fluff may be there, or there will be dead tendons may be there, dead skin may be there. All those things are debrided. Okay, then you can carry out the other debridements. And the biological debridement which is there, you know, how do you do a biological debridement? Manisha, any idea how do you do a biological debridement?
No, sir.
Biological debridement is done with the help of the maggots. You know, the uh, house flies which are there, and you must have seen that there are
Yes, sir.
maggots on the ulcer which is there. So the
Yes,
similar
sir.
maggots are there, but not from the house flies. There are special type of the flies which are there from where you obtain the maggots. They are called as green bottle flies. Okay? They are green bottle flies, and the type of the fly is Luceria. Luceria fly is there. The species which is
Yes, yes, sir. Lucilia sericata.
yeah,
Yes, sir.
the maggots of that is used for the biological debridement.
Yes, sir.
Okay, so you can have the debridement, and then there is a special principle which is used for the wound bed preparation, and that is called the time principle. Any idea, Manisha, what is time principle?
Mm, sir, sir, no, sir.
Time principle is basically T is
Sir,
for
it is
tissue. Tell, tell that. What is time principle?
sir.
T is for
T
time.
is
time, I is for infection, M is for moisture, and E is for H. So this is the time principle. T for tissue, I for infection, M for moisture, and E for H. So tissue which is there, so if there is any dead tissue is there, you have to do the debridement of that. Okay. I is that you have to control the infection. So control of infection will be by taking care of the infection, and also, you know, what is the biofilm? Have you any idea about the biofilm?
Yes, sir. It is created by species like Pseudomonas. They create a biofilm so that they become resistant to antibiotics.
Biofilm is like a film which is produced by the various type of the bacteria, and it does not allow the penetration of the antibiotics. So always you can use antibiotics for that, but the main treatment for the biofilm is the debridement. You have to debride the wound to control the biofilm. Okay, so infection which is there will be taken care by the antibiotics, and also the debridement is very important. Then M is the moisture. What does the moisture stands for? What is the meaning of that? You know, you have to always keep the wound on the moist side. It should not be dry. So if there should be not too much of the moist also, that there is a lot of the secretions which are coming out. But it should be slightly on the moist side rather than the dry side. So you have to keep your wound in the moist environment. And the way that when you're using like the dressings which are there, you should use the dressings which provide the moist environment to the ulcer. And then is the edge. Edge is because you have to keep that this edge should become a sloping edge. So that should be the aim that that ulcer heals. So that is the time principle. So you have to take care of the tissue, you have to take care of the infection, you have to take care of the moisture, and you have to take care of the edge of the ulcer. Okay. So if you keep your patient on this treatment, then in that case you can find that this ulcer heals up. So for the healing of the ulcer, you have to take care of all the systemic causes, and in the systemic causes, the most important is the diabetes. Okay. Now, if the patient is a diabetic patient and there's a big ulcer is there, you know, how will you control the diabetes? How will you control the diabetes?
Blood
By
sugar
giving
control.
him insulin.
It's always
Sir,
preferable,
oral hypoglycemic agents or
not the
insulin.
oral one, it is always preferable to give the insulin preparation.
Insulin.
And that also, not the long acting one, but the short acting one. It's because in a patient who has got ulcer, there is a chance of having a fragile type of the diabetes. And fragile diabetes means that if you give the patient like the long acting, or you give the patient oral anti-diabetics, then in those cases, the patient may go into hypoglycemia. That you have to be very sure that the patient does not go into hypoglycemia. And that is why it is preferred that you control the diabetes on the short-acting insulin J. Right? Now, this ulcer can be ischemic ulcer. So what are the things which can be done for the ischemia?
Sir, from surgical point of view, we can do bypass or sir,
Revascularization.
and angioplasty. I mean, revascularization procedures.
So if there is it is a ischemic ulcer, then you should always try that if it can be revascularized. And revascularization can be done. What are the various ways you can do the revascularization? Like if there is a block is there, like the femoral artery block is there, then what are the ways you can do the revascularization?
Sir, angioplasty or bypass.
You can basically divide into two types. One is the open revascularization, and second is the endovascular. Endovascular. The open, like if there is a block in the popliteal artery is there, you can carry out a bypass of that. So bypass can be done with the help of either a graft which is there, or much better that you take the autogenous tissue. So which is the common autogenous tissue which can be used for a bypass grafting?
Great saphenous vein.
Great saphenous vein. Okay. So great saphenous vein is one of the most important autogenous type of the graft which is available. So you can do the autogenous vein grafting, and this can be always a reversed vein grafting. Reverse vein grafting means, how many walls are there in the great saphenous vein? How many total walls which are there in the great saphenous vein? Any idea?
No, sir.
There are around 10 to 15 walls which are there. In the great saphenous vein, there are 10 to 15 walls which are there. Do you have the wall in the inferior vena cava? There is no wall in the inferior vena cava. There is no wall in the iliac veins, but in the great saphenous vein, we have 10 to 15 walls. So you have to always, whenever you are doing a grafting, you have to always reverse that. And that is why it is called as a reverse saphenous vein grafting. Because if you do not reverse, the blood flow is unidirectional. So you want that the blood flow come from the proximal to the distal side, and that is why you have to reverse the saphenous vein for carrying out the grafting. But you can also do what is called an in-situ venous grafting. In-situ venous grafting means that you do not take out the saphenous vein from its place. It remains at the same place, but you do the grafting. But because now the direction of the flow which is there is unidirectional, so you have to destroy the walls there. And these walls are destroyed by the valvulotome, that you put an instrument in the vein and you destroy the walls there, and then you do the grafting there. and that is called an in-situ venous grafting. That you are not taking away the GSV from the bed. It is in the same place, but you are destroying the walls by the valvulotome, and then you are doing the graft. So that is the open type of the procedure which can be done. Or you can also do the endovascular. Now, endovascular is like a angioplasty which is there. So you will do the dilatation, and you can put the stent in that. In the obstructive segment, you can put the stent. So if it is ischemic ulcer is there, you are going to do the revascularization, and then this ulcer will heal. Now, if it is a venous ulcer, what can you do?
Sir,
If it is a venous
first
ulcer,
of all,
then
we
what can
will,
you do?
sir, first of all, we will ask the patient I mean, we will keep the limb of the patient elevated, uh, and sir, apart from that, sir, we will provide 4-layer dressing on the ulcer, and we will keep usually the pressure we keep is 35 to 40 mmHg if the ABPI is in the normal range, and uh, so that's it. And if there is any infection, then we will give antibiotics. Otherwise, if there's no infection, there's no need of antibiotics.
And then you have to always take care of the pathology which is there, which has caused the venous ulcer,
Yes,
the
sir.
varicose
Yes.
veins which is there. So you have to
Yes, sir.
take care of the
Surgery
varicose
for that we
veins.
will do.
Usually, nowadays by the endovenous treatment which is there, so you can do the laser treatment of the veins or the RFA for the veins along with the 4-layer dressing, and that will probably heal the venous ulcer. Okay, so tell Manisha what you will do for this patient. What will be the treatment for this patient? Who is not diabetic, it is a post-traumatic one. There is no ischemia. So what are you going to do for this patient?
Sir, we will clean the wound, then apply dressing, and then we will give him antibiotics based on the culture sensitivity that we have sent. And once it is once it has healed, once the ulcer has healed, we can do skin grafting.
Ulcer will not heal you. Ulcer, and then your healed ulcer, you do not require skin grafting. So once,
Sir,
what you tell, the wound bed is prepared. That's what I was telling you that
prepared.
once
Yes,
the
sir. Yes, sir.
wound bed is
Time to prepare.
prepared,
Bed is prepared.
then you will do a skin grafting of that. You will put in this area because here probably no joint is involved. So you can put a skin graft here. So what type of the skin graft you are going to put? What
Sir,
type of the skin grafting you are going to put here?
sir, autograft.
You know what are the various types of the skin graft?
Sir, it can be autografting, allografting, and uh,
So in this patient, which type of the, it can be allografting,
yes, sir.
it can be a heterografting, or it can be
Heterograft,
xenografting, or xenografting. Xenografting is from the animals, hetero from the other person, and auto is from the same person. So what type of
same
the
person.
grafting you will do in this patient?
Autografting.
Autografting. Okay, you do autografting. Now in autografting, what type of the graft it will be?
Sir, I couldn't hear the question.
Now, what are the various types of skin graft?
So here we may use a full thickness skin graft because the whole thickness of the skin is gone.
So basically, the skin graft is either a partial thickness skin graft or the full thickness skin graft. You know. So here, what type of the graft you will use? Full thickness or partial thickness? Mohit?
Full thickness.
The full thickness because the skin has been lost completely.
No, you will not be able to put a full thickness graft here. The full thickness graft will never survive. It's a big area, you know, almost about 10 centimeters in size or more than 10 centimeter. Here, you cannot put a full thickness graft because full thickness graft will not survive here. So you are going to put only the partial thickness skin graft here.
Okay.
If you have to put the full thickness here, then you have to put a flap here. You know, Mohit, what is the difference between a graft and a flap?
So a graft is just a transplanted tissue, whereas when we use a graft, we use the blood supply of that particular skin piece.
Flap?
So in flap, we also use the blood supply of that particular tissue,
Which is detached from the body. Graft or a
yes.
flap? No,
So
which is
graft.
so graft will be detached from the body and applied over the recipient area. Okay.
It will use
While
the blood
flap
supply of
will have
recipient
its
area.
vascular supply.
Yes,
And do you
sir.
know what is a free flap?
Sorry, sir.
Free flap.
Pre-flap.
Free flap, yeah.
Yes, sir. When the tissue is taken with its blood supply and transplanted to a new position.
So it is a type of flap. Means it has got a lot of tissues. Like it can have the full skin. It may be along with the subcutaneous fat or the fascia or the muscle or even the bone. But it is detached from the body. And then it has got the vessels, artery and the vein, and they are anastomosed over the recipient site.
So we use it in oral reconstruction surgeries,
Yeah,
pre-flaps.
yeah, in the oral reconstruction, anywhere, you know, breast reconstruction, oral reconstruction,
Regular flaps are
anywhere the
used.
defect is there, you can use that. Okay.
Yes.
So in this patient, out of all this, your first choice will be to use a partial thickness skin graft, not the full thickness. Full thickness is for the small areas because you can obtain only very small amount of the tissue there. So like you can take from the back of the ear, a small tissue can be taken, or from this supraclavicular region, you can take a small amount of the tissue, and that can be put as a full thickness. But if it is a big defect is there, then you can either put a type of the partial thickness skin graft or you have to use the skin flap. So here you are going to put a skin flap, the skin graft here, and that will heal the ulcer. So this is the treatment in this patient. You will control the infection, you will prepare the wound, and then put the skin grafting over that, and that ultimately will heal the ulcer. Okay. Any question anybody wants to ask?
So what was the 4-layer dressing?
Manisha, tell what is the 4-layer dressing?
Sir, in 4-layer dressing, the first layer, it is also known as Una dressing, and the first layer we use is of a orthopedic wool. The second layer is of a cotton crepe. The third layer is of elastic bandage, and the fourth is the adhesive bandage or cohesive bandage.
So this is a 4-layer dressing which is used. Now you can also use the 2-layer dressing, but the most effective one which has been found is the 4-layer dressing, which has got the
4-layer dressing.
different components. As Manisha told about that, what are the various components? And you apply this dressing over the ulcer, and you keep a pressure of about 30 to 40 millimeter mercury.
35 millimeter.
And this dressing is left for about 5 to 7 days and then change that. And this is probably the most effective method of healing of a venous ulcer. It is for the venous ulcer mainly.
So then can't we use negative pressure dressings instead?
You can use, yes. Yeah, you can put like in this ulcer also, no, if you are thinking there's a lot of exudate which is coming out and you want that this should shrink in size, you can put the negative dressing.
Okay.
Sir, what was the point regarding that charcoal food? That I did not understand charcoal food.
Charcot's foot is a part of the diabetic foot which is there, where you will get, in the diabetic patient, you can have the osteomyelitis or you can have a osteoporosis. So in the osteomyelitis, you will find that the bone is getting thickened. While in the case of the osteoporosis, it will be that the bone is getting thin, not the thick. So if there is a osteoporosis of the bones and the joints which is there, that is a part of the Charcot's foot. Okay.
Okay.
So apart from ulcers, can you tell us something about the wound dressings that we do on a daily basis? Like ऐसा wound है तो ऐसा dressing करना है, something like that.
The best dressing which is there is called as the moist normal saline gauze dressing. Okay. There are thousands of dressings which are there and very expensive type of the dressings which are available. But if you have to give answer in your, so if you are getting a MCQ that which is the best dressing, and you get a question, the choice which is there is a soaked normal saline gauze piece. Okay, so that will be your answer of choice. Otherwise, there are so many types of dressing, like there are the colloid dressings which are there. Then in the advanced one which are there, like the biological dressings which are there, where there are keratinocytes and all those things which are there. So almost more than 100 types of the dressings which are available. But the best answer is a moist normal saline gauze dressing.
Thanks.
Okay.
Yes, sir.
Yes, sir.